Good morning and welcome, everybody. We're excited you're here to join California Quality Collaborative's Resilient Primary Care webinar today on primary and maternity care integration. We're really excited you're here to join us, and we look forward to discussing with you today. I know that many of us are pretty familiar with Zoom these days, but just a couple of quick tips and reminders. If you have any technical issues throughout this webinar, please direct chat me, Michelle Ma, and I will be happy to assist you in any way I can. Um, we will be uploading a PDF slide deck into the chat box if you'd like to follow along, and you can download that. There's a feature to download. You just click you might see a download or a blue arrow. And as a reminder, this webinar is being recorded and will be available for viewing later on. And we do like to take a couple polls here. So when you do submit your answers, please be sure to click the blue submit button just so that your vote or your answer can get captured. And we're gonna move ahead to our very first poll. We just like to see from where everyone is joining in and of what type of organization you represent. So you can see the poll has been launched. If you could vote and also scroll down um, because there's a second question there. And after you're done voting, if you wouldn't mind chatting in your name and your org, just so we can see some names and some familiar faces as well. We'll leave this going for a couple more minutes. Welcome, everybody. Thanks for joining us. Looks like we've got people from all over the place. Thanks for joining. We're glad you're here with us. We'll give everybody a couple more seconds. Okay, I'm gonna close this poll. And so thanks everybody for joining. We're really glad you're here. And at this time, I'd like to turn it over to our facilitator, Blair Dudley.
Hi, everyone. Thank you very much for joining. We are very glad to be joined today by a diverse audience of both primary care and maternity care stakeholders. And I want to give just a little bit of background on what is CQC. So CQC is the California Quality Collaborative. It's a healthcare improvement program of the Pacific Business Group on Health, which is dedicated to advancing the quality and efficiency of the healthcare delivery system in California. Governed by a multi-stakeholder committee and administered by PBGH, CQC generates scalable and measurable improvement strategies in care delivery through its learning collaboratives and train the trainer approach. And now I want to tell a little bit about this series that you've joined us for today, called Resilient Primary Care. So CQC's Resilient Primary Care webinar series supports practices to build and strengthen internal capacity through facilitated peer learning and spotlighting successful practices. This series covers topics relevant to both the foundation of high-performing primary care and healthcare innovations that will bolster practices as they adapt for the future. And now I want to just go over today's objectives for this webinar. So today we will define the key elements of primary maternity care. We'll discuss opportunities to reimagine maternity care and the potential impact for patients. We'll identify foundational elements that primary care and maternity care providers need to support healthy pregnancy and birth. And we'll hear lessons learned and successful practices from leaders in the field. And just a little bit on PBGH's maternity program. Our mission is to promote high-value maternity care in the US by decreasing preventable maternal morbidity and mortality, including physical and mental health, promoting patient-centered maternity care and addressing healthcare disparities, and aligning payment with outcomes. We design, implement, and spread care models that support vaginal birth, reduce primary C-sections and early elective deliveries, and encourage early screening and treatment. We accelerate transparency through measurement and accountability, partnering closely with folks like the California Maternal Quality Care Collaborative and Integrated Healthcare Association. And in response to consumer demand for choice in care team and care location, we promote the use of midwives, birth centers, and doulas. We educate birth participants on high-value maternity care, and we work closely with health systems and providers, health plans, and employers to design payment models that support the best outcomes for patients. So now we're going to do another poll because we'd like to take the temperature with y'all as our audience. So if you can take a look and see how much do you agree with the statement, maternity care is primary care?
I don't know if that's, did everyone see that poll or was that a different poll that jumped up?
Came up for me.
Okay, thanks, Blair.
And while we're getting some of our poll results back, I'd like to introduce our speakers who are joining us here today. And I'll start with Amy Romano. Amy is a maternity care leader focused on care model innovation, community integrated care, and quality improvement. With a clinical background as a nurse midwife, Amy has spent her career working to improve maternity care and has particular expertise in primary prevention of cesarean and preterm birth, midwife-led and collaborative care models, shared decision-making, and quality improvement. Amy is the founder and CEO of Primary Maternity Care, a consulting services company focused on strengthening community-based care models to improve maternal and infant health outcomes and reduce disparities. We are also joined by Dr. Pooja Mehta, who is a board-certified practicing OBGYN and the Women's Health Lead of Cityblock Health, which is the first tech-driven provider for communities with complex health and social needs, bringing better care to neighborhoods where it's needed most. Prior to Cityblock, Dr. Mehta served as interim chief medical officer and chief clinical innovation officer of Louisiana Medicaid and medical director of the Louisiana Perinatal Quality Collaborative and Maternal Mortality Review. Dr. Mehta practices clinically with a reproductive justice informed focus on obstetrics, family planning, reproductive infectious disease, and LGBTQ health. Thank you very much, Amy and Pooja. We're very glad to have you with us.
Thanks. Hi, everyone.
Hi, everyone. Good afternoon or morning.
So now I just want to show a little bit of what we heard from you. So thank you for everyone for registering for this webinar and for sending us your questions. So we heard that you would like to know more about operationalizing primary maternity care in the provider office, improving communication between pregnant individuals and their providers, providing longitudinal care, measuring quality indicators, particularly that increase accountability, supporting maternal mental health, ensuring birth equity, integrating community organizations, and supporting employees to better align maternity care quality with the employee experience. Thank you very much. And with that, I'm going to pass it over to our guest speaker, Amy Romano.
Thank you, Blair. Hi, everyone. I appreciate this opportunity and I'm excited to get to collaborate with PBGH and CQC as well as Cityblock Health today. So I wanted to begin, are we doing the poll results? Sorry, at this point or?
I think we had a little technical difficulty with the poll results. So if we're able to pull them up, we'll do that at the end. Thanks.
Okay, we can do them when we, actually, can you back up one more slide, Michelle? Thanks, I got thrown off by that. So in this part of the presentation, we're gonna look at how maternal and infant health relate to population health and therefore to primary maternity care services. We're going to look at the concept and define the concept of primary maternity care. And then we're going to look at some promising models at the intersection of primary care and maternity care. Next slide. So I wanted to ground this first in looking at kind of how maternal and infant health relate to population health overall. And you can bring the first bullet. And I'd like to ground these conversations in just the concept that everyone is born. And so there really is almost no other area of healthcare except for end-of-life care that truly affects all of us. And when we think about what makes for a healthy population, we need to start from where literally the population starts. So everyone is born. Next bullet. And we know that the maternal health and well-being impacts the infant and the child for longer term. And there's an indigenous midwife called Kaji Cook who has referred to the mother as the first environment. And so if we can think about sort of what promotes either well-being and health or illness and back it up to before the baby's even born and as the fetus develops in utero, it's easy to imagine what the differential impacts of a state of hunger versus nourishment might be, or a state of trauma versus love and support, or a state and condition of pollution versus having access to clean air and water. I don't think it takes a lot of imagination to understand how those could impact the health of the child. And we do in fact have good evidence and a growing body of evidence that childhood chronic disease, things like asthma, childhood obesity, and certain learning and functional problems are linked to maternal health and maternal illness. Next slide, or next bullet. And we also know that the mother's health can be impacted by pregnancy, and that pregnancy can actually trigger a number of chronic diseases or exacerbate or accelerate their development. So we know that diabetes and blood pressure conditions in pregnancy are markers of elevated risk or are in fact the early stages of developing lifelong conditions in those areas. And we also know that weight gain associated with pregnancy is often sort of part of a cascade that leads to longer term obesity and some of the health issues related with that. And then lastly, we also know that pregnancy, the other side of that coin is that pregnancy can trigger healthy behavior and salutogenesis, which is a concept I know many people maybe have not heard of, but it's really just the flip side of pathogenesis. It's health creation. So we all, those of us who've been pregnant or just know the experience of being pregnant, know that people are often very motivated around making behavioral changes, whether that's the foods they eat or starting an exercise regimen. Cessation of smoking and other substances frequently occurs. And again, motivation levels high in pregnancy. And also the social connection and community building that pregnant people do and postpartum people do is actually health creating. And we know that there are health effects of having those stronger connections. So there's a real opportunity not just to prevent disease, but to create health and to build the foundation for a healthy population. Next slide. So, and if we just reflect, and I don't know that we'll know the results of our poll, but I feel that at least the primary level of maternity care is absolutely primary care, because if we think about what the word primary even means, what's first, what kinds of things are most important, what's fundamental to the health of a society or a population. Next slide. And when we look at the concept of primary maternity care, this is one that's not well understood. It's probably not terminology that many on this call have used or heard. This is my favorite definition of primary care. It's a lot of words, so I'm going to go ahead and read it. Primary maternity care is the umbrella term for the fundamental healthcare services that women access during pregnancy, childbearing, and the postpartum period. It takes a holistic, woman-centered approach to service delivery, health promotion, and the prevention and treatment of disease and illness. Primary maternity care is the first contact with our healthcare system for maternity care needs, is part of a comprehensive maternity care system for a community, and includes plans for addressing the needs of women and their infants who need care from other providers. It's based on the philosophy that pregnancy and childbirth are natural processes that require a focus on health and should be individualized. Within the context of primary health care, it is an important way of working towards developing healthy communities. I don't think it will surprise many of us that this is not an American definition, because our system, as we'll get to, doesn't really look like this, but this came from a national effort in Canada to strengthen their primary maternity care systems through collaborative care at the community level and expansion of the use of midwives and family practice providers in Canada. And this slide, which has a lot of content on it, so you can take a closer look when you get the slides after the talk, comes from a Lancet series where a global group of researchers established a framework for quality maternal and newborn care. And so this was really a multi-stakeholder effort to define what the fundamental services, practice categories, values, philosophy, and so on are of a maternity care system. And so you can see from this that everything but that upper right-hand corner that's in the pinkish red are the services that really everyone needs. And then that upper right-hand corner represents the care that childbearing women and infants with complications need. So really an organization of care that is available, accessible, that integrates values of respect, communication, community knowledge, and so on. And I don't want to spend too much time on this slide, but again, you'll have the PDF, and I see it there in the chat. We can move forward again. So when we get down to like what are literally the things or the services that everybody needs and that we can consider essential and fundamental, it's things like routine visits, both prenatal and postpartum. There's many types of labs and imaging that basically everybody gets and that are routine, and obviously others that are more condition specific. Preventive care, whether it's wellness types of services, vaccines, and different kinds of screenings. There's a lot of education and shared decision-making, monitoring for complications, coordinating higher levels of care, urgent care and triage throughout the whole spectrum from preconception through postpartum, as well as first-line management of conditions, screening and integration of services for mental, social, and behavioral health support, coordination of community-based services and social supports, access to risk-appropriate care for the birth itself. So we've either a facility or provider to care for you in the community and to access higher levels of care as needed. And then dignity, autonomy, safety, and support throughout the entire process. So these, again, are things that all people need and benefit from, and that are not very controversial, I would say, as far as whether we should be trying to provide these to pregnant people in our society. But you can move ahead, Michelle. The reality, as I'm sure many of us are aware, is that this same list of services are, though they're things that everybody needs, it's really the exception rather than the rule that people access this full bundle of care during their pregnancy. And if they do, it's not in a coordinated way. So they may be paying out of pocket for certain things. They may be, that would be true of things like education and certain wellness services, various kinds of mental health supports. They may have to pay out of pocket. They may have to go to multiple locations to have different services provided, and so on. And so while we can imagine what primary maternity care is from a substance perspective, it's actually pretty hard to access this. And we know as well that there's entire communities, especially in rural areas, but also in some urban areas where there's no services at all and a complete desert. So we can move on. And so I think when we think about reimagining our system or being resilient as we rebuild from the COVID-19 pandemic and just from the crisis that's been brewing all along, I believe it boils down to the way that our system is designed. And designed here is in quotes, because I believe that our system really isn't designed. It's a very kind of haphazard patchwork of services and structures and forces that really have not been thought through from a kind of human or systems level approach. So we have specialist care basically for everyone. The standard of care in this country is for obstetricians to see basically everyone, unless they kind of pass the test and can access a midwife. That's the opposite of how it's approached in many other countries, because obstetricians are specialists, they're surgeons, and not everybody needs that level of care. We also have tertiary care as the gold standard, and this concept of kind of 24/7 high risk care available to everyone as what we should be striving for in in many of our communities. We have payment tied to procedures and poor outcomes. So it's things like NICUs or additional ultrasounds and tests that drive payment rather than good outcomes or preventing poor outcomes. We also have just frequent testing. Pregnancy is a biologically normal state, and there's been this expansion of kind of what we test for, how frequently we test, what kinds of things we can test continuously for, and that all leads to kind of a narrowing of the concept of who's low risk as we kind of have the medical capabilities to identify various different risk factors. And this drives a lot of the excess intervention that we see in our system. And then the other side of that is that the things that we know are high value and that have a potential to prevent poor outcomes are often the very things that people are paying out of pocket for. So people face higher out of pocket costs for doulas, midwives, and birth centers, even though the evidence base for all three of those models of care is very strong. And, and yet, again, people have to sort of be consumers about it and decide that it might not be valuable enough for them to spend their scarce resources. Nutrition and fitness programs, again, are often not covered, even though obviously they can benefit pregnant people and their newborns. Mental health support and childbirth and parenting education. So these things are kind of outside the bundle of clinical care. So if we imagine how we would design an optimal maternity care system, this slide comes from that same effort in Canada to define and expand collaborative primary maternity care. And so the notion is that you start down in that bottom left-hand corner with what the needs of people in the community who are giving birth and their newborns in fact are. And so it starts with community engagement and community understanding, leading to providing care from a collaborative team that directly provides the majority of care and enables access to all of the potential core competencies needed for the range of different pregnancy scenarios. But we really see this broad base at the bottom of the triangle of primary maternity care, where that's the entry point for everybody, and it's the widest part of the schematic. So it's the majority of care, and then sort of leading up the chain to higher levels of care as needed, and in a continuous kind of improvement loop for ongoing evaluation, improvement of outcomes, and ongoing engagement to identify and promote the needs of childbearing people. So we wanted to pause here and see, as we look at this image, and we'll talk some more about some specific tactics, but how does this resonate with you? Are you seeing a shift toward these kinds of ways of thinking? We'd love to just see in the comments thoughts or questions. And Blair just posted the link that's in the tiny little font at the bottom, and it's a really interesting read. And there's some follow-up studies that have been done, including one with the title of Easier Said Than Done. So even in Canada, that has some of these systems kind of a little more well-oiled, there are still cultural barriers and structural barriers to its kind of full implementation. So we can move on, I guess, if people don't have questions at this stage, but think of your questions, because we're going to pause a couple of other times coming up for reflection and discussion. So in the next part of this talk, we're going to get into some of the opportunities at the intersection of primary care and maternity care, beginning with urgent care for pregnancy and postpartum people. And then opportunities in the early pregnancy period, when people are often presenting in primary care locations for confirmation of pregnancy or early pregnancy support. And then we'll look at wraparound services and support and more kind of comprehensive approaches to the intersection of primary care and maternity care. So one of the areas I wanted to focus on is urgent care. I think there's been a lot of interest in the hospital as the location for the vast majority of births and the potential to move some of those births out of the hospital. But there's a lot of other things that happen in the hospital that don't need to, and that drive up both the cost of care and create quality and safety issues for patients. So we know that ED use is extremely common in pregnancy and the postpartum period. The rates in the literature are a little bit all over the place, but up to 84% in one study of postpartum moms reported using the ER at least once in pregnancy. And in pregnancy, the likelihood of needing an admission from an ED visit is very low. In one of the studies, it was reported at less than 1%. It may be higher than that. It may be, so there's some data issues, but the types of things that present in the emergency department in pregnancy are often low acuity issues and the result of lack of access in the community, as we can talk about in a moment. In the postpartum period, some of the issues are a little bit more likely to be higher acuity problems, but still the majority are not medically needed and don't result in an admission, and same with newborns. So there's a lot of kind of normal learning curve of parenthood and common kind of self-limiting conditions that people seek help for in the emergency department, things like feeding issues and mental health issues that are better served in other specialties. The other thing is that urgent care centers and primary care centers often won't assess and treat pregnant people. So you could be a pregnant person with flu symptoms or COVID symptoms for that matter, and try to access a testing or care in an urgent care and be told, we don't take care of pregnant people here, or you're too far along. There's first of all no continuity in terms of what the rules are. So some places will see you, but not for pregnancy related conditions and so on. But basically access at urgent care centers is really poor. And people that present in the ED or urgent care have care that's disconnected from their primary care in their pregnancy. They're getting care from people who may not have much perinatal training. And so there's a lot of quality issues and just variation in the experience and care there. And these are two quotes from a focus group I did last March, just the last time I went anywhere before the pandemic. You can show the first one. These are moms that had just had a baby, and then this mom said, I've gone to the ER almost every pregnancy, mostly out of anxiety, not medical need. One time I went, it was a Saturday night, and I was like 9 weeks pregnant with him and had a cease of all my pregnancy symptoms, and it just worried me, and I had to go to the ER. I didn't have to, but I chose to. Everything was fine, obviously. It was frustrating to have to go to the ER. So she was 1 month postpartum, but she'd had 2 prior losses in the second trimester. So she was someone who had good reason to feel anxious when her normal pregnancy symptoms suddenly went away, and would have been well served by a home visit from a nurse or just someone to reassure her. Next quote. With my first, I had hyperemesis, which is severe nausea and vomiting, which usually requires IV therapy. I had to go to an urgent care near my house. I went there, and basically it was hard to figure out if they would take me or if they would send me somewhere else. I ended up not getting treated because I didn't know what was covered, and it was really confusing. But yeah, I went for weeks being severely dehydrated in my second trimester because I didn't feel like I had anywhere to go. So obviously access issues and quality issues as well, and just a lot of unnecessary navigation that people who don't feel well and have a lot of just educational needs are forced to do. Next slide. So some strategies that could address this without a lot of major system transformation would be simply to integrate midwives and other perinatal workers into existing urgent care services. The vast majority of types of things that are sort of same day appointment requirements for pregnancy are things that are well within the scope of midwifery scope of practice. And so midwives with obviously collaboration and consultation and referral mechanisms can really serve a large number of people. And midwives can also do a broad range of other primary care, gynecological and general primary care for women and newborns in urgent care services. You could also expand urgent care offerings in community-based facilities or practices. So I personally think that birth centers, midwifery-led birth centers are a good place to look at an expanded, integrated urgent care offering, because there's so much of the infrastructure that goes into running a midwifery-led birth center is the same kind of infrastructure you need to address urgent care types of concerns. And then you could, in combination with these or in combination with other models, you could utilize telehealth or teleconsultation, where you could get, for instance, obstetrician input in a community-based primary care location by simply teleconsulting them in. So the next area after urgent care that there's a lot of opportunity is in the early pregnancy period. And this is a time, again, when I think a lot of people do present still to their primary care provider. But when they get settled into prenatal care, they're often offered a visit between 10 to 12 weeks at least for their first visit. And that's really driven often by scheduling issues for the practice, or by when the various tests need to be done, whether that's for genetic conditions or listening to the baby's heartbeat, those kinds of things. So those are kind of the medical needs drive the timing of this first visit, rather than the patient preferences or what their individual needs are. And the other thing is that there's a very high rate of uninsurance in this time. So I think it's about 20% of people are uninsured in the month just prior to getting pregnant, which means they're navigating their insurance, they're trying to get enrolled in Medicaid, or they're trying to get themselves on some other plan during this time period, which of course can delay entry into care, especially in states that don't have presumptive eligibility rules. And this is a time of high need for information. There's a lot of education. They're Googling everything. They need support. They often don't feel well, but there's not actually a lot of need for clinical medical care. So more simple interventions, more community-based interventions can do a lot in this window, because it's also a huge window of prevention opportunity. So things related to nutrition or medications people are on, getting a good solid information to figure out the due date. There's all kinds of things we could be doing in the first trimester that are kind of missed opportunities if we're not laying eyes on someone until they're 12 weeks. So the case that we wanted to look at, this comes from Baby & Co., which was where I used to work before I was at primary maternity care. And Baby & Co. is a 4-site network of midwife-led birth centers. And we were integrated with different regional health systems and operated in a few different states. The model of care overall was very education intensive, wellness oriented, family centered, and focused for the birth, although we offered hospital birth as well. The focus was on natural childbirth. And we, I think this was in late 2018, early 2019, started a QI project focused on early pregnancy care. Our goals were to identify prevention opportunities and engage clients in a plan for healthy pregnancy, and specifically around development of gestational hypertension, gestational diabetes, and preterm birth. In that order, those were the things that people would risk out of our care for. So they would come in with an interest in low risk birth and midwifery care, and over time develop gestational hypertension or one of these other conditions. And we looked at some of our data and realized we weren't really most of these people were very easy to identify. The people ultimately got diagnosed with hypertension were very easy to identify early in pregnancy as people with risk factors. And so we felt that if we were a little more organized and proactive, there were some prevention opportunities that we could take advantage of. We also saw this as an opportunity to just improve the client and family experience. We had gotten feedback, so we were addressing some of that. And then just to provide education, support, and a lifeline, so a place that people can call that's not the emergency department if they have bleeding or nausea, those kinds of things. So the intervention we did started with a design of a visit called Start Right Now, which was specifically designed to be an early pregnancy visit that people would have before 10 weeks of pregnancy. You can go forward. And so part of the intervention was just to simply offer as early as possible. So we really did a lot of operational work to open up schedule visits and so on, and be able to really accommodate people basically as early as they were interested in coming in. And we also designed and implemented a standardized prevention opportunity screening. So this was screening and algorithm to identify people at high risk of developing one of these conditions, and then prevention plans that went with people who were identified as moderate or high risk. And so this was meant as well to identify people with multiple moderate risk factors that would kind of impose high risk of these conditions. So, and the kinds of prevention kinds of prevention plans that we recommended were aspirin, which is a basic and evidence-based intervention for preventing hypertension, nutritional supplementation with calcium and other supplements, and a Mediterranean diet, aerobic exercise. And we had health coaches integrated with our program of care who would do specific outreach to these people as well. And we developed some classes and things to support the education. So we rolled this out. You can go on to the next. This was the preliminary data. And again, I don't work there anymore, so I don't have the sort of follow-on data, which I'm very interested ultimately in. But we did a before and after looking at people who ultimately did develop gestational hypertension or preeclampsia in the pregnancy. So pre-intervention, we had less than a quarter of people that established prenatal care prior to 10 weeks. And after the intervention, we were successful in getting about 2/3 of them in for those early visits. The prevention opportunity screening didn't exist initially, but after implementation, we had widespread use of it. So 86%, we did a pretty good job of doing the screening. We did have people misinterpret how to use the algorithm. It was a paper-based algorithm and needed some more design thinking, clearly. But despite some of the usability issues with the algorithm, we went from 12% to 100% of people who had at least one prevention recommendation as part of their first trimester care that was focused specifically on reducing their risk of gestational hypertension. So either aspirin, Mediterranean diet, those other things were recommended. And while this is definitely not outcome data that I think we can hang our hats on at all, it was interesting preliminary data. Again, these are people that did ultimately get hypertension in the pregnancy, but prior to the intervention, more than a quarter of those were diagnosed prior to term. So they had preterm births as the way to manage their developing hypertension. And after the intervention, we were down to 12. So potentially there's something, it could be that we moved the sort of timing. We pushed the pregnancy a little further along before the complication developed. We also saw a big increase in the number of people who ultimately developed the condition that had no risk factors at the beginning of pregnancy. So again, before the intervention, really the motivation for doing it was like 70% of our people had something telling us at their very first visit that they needed some additional level of support or intervention, and that we could do something evidence-based to prevent this. And we saw that go down. Next slide. So the lessons we learned from this, again, are pretty preliminary, but we do feel that a person-centered approach to early pregnancy care increases access and choice for people. The prevention opportunity screening really supports identification of people who would benefit from evidence-based prevention strategies. All of the strategies we implemented were things that there are studies that show they work. They just, are hard to implement in our fee-for-service program system. The screening tools really do need to be validated, designed for usability, and better integrated into standard workflows. But prevention of what I really believe are lifestyle-related conditions of pregnancy requires a coordinated team-based approach, including lots of non-clinical support, education, health coaching, social supports, and so on. And I think this is the last slide for this case study. I think we do have some time for questions before we get into Cityblock.
Thank you, Amy. And we did have a great question just come in from Katie. How did you pay for the interventions for GH prevention? Was this grant-based, or did your patients have the ability to pay for health coaches?
So it was a investor-funded initiative, and I thought it was really interesting, actually. As I mentioned, it was a birth center model. And as part of that, we were really incentivized to keep people healthy, because if they developed hypertension or diabetes, they were no longer eligible to give birth in the birth center. And our overall kind of financial model was driven by recouping those facility fees on enough patients that it would kind of cover the overall program of care for everyone. So it was, the case to the investor, because again, these things were not individually paid for. We did have bundled payment arrangements, and so we had, negotiated some higher rates on the basis of having an enhanced care model. And then internally, we felt if we could prevent just a couple of people from developing a complication that would risk them out, it would pay for these additional things. And because of our bundled payment arrangements and just the general approach to global fee for service, even for the plans that we had, that we did not charge for a health coach. We had preconception programs where people would pay out of pocket for a health coach, but once it was within the pregnancy episode, we had to figure out a way to pay for it internally. But it helps when you're incentivized to keep people healthy. You can do things like this. At least pilot them.
Thank you, Amy. And Michelle, if you go to the next slide, there's a question that I want folks to just be thinking about, and we'll move on to Dr. Pooja Mehta's presentation, but just be thinking about this question as we get into our Q&A after Dr. Mehta's talk. How can primary care providers benefit from coordination and integration with maternity providers? And how do maternity providers benefit? So thank you very much, Amy, for enlightening us on some of the opportunities at the intersection of primary care and maternity care in the urgent care space, in the early pregnancy prevention and planning space, and in terms of those wraparound services and support. So please, to the audience, please continue to chat in your questions. And I'm going to go ahead and pass it over to Dr. Pooja Mehta.
Hi, everyone. It's great to be here. And I'd like to just offer a second case study following on some of the themes and frameworks that Amy has provided us, which certainly have been thought-provoking for me, even as I think about our own work in the context of this definition of primary maternity care. So Cityblock Health is an advanced primary care organization. We're a provider organization that offers value-based care to historically marginalized and underserved communities that are identified by payers. And we were founded in 2017 on the premise that health is local, and that by uniting primary care, behavioral health, and social services, we can address some of the root influencers of health and be tech enabled, but be able to show up face-to-face for people in order to support their health and wellness. So what is an OBGYN doing at a primary care organization? In the case study section of a talk about primary maternity services. Well, after years of both working as an OBGYN in a traditional hospital system, after working in Medicaid as a clinical leader, and thinking about the payer side, after working in obstetric triage in the middle of the night in the hospital, really having an epiphany that even with a perinatal quality collaborative approach where we were trying to focus on hemorrhage and severe hypertension and responding to emergencies in the medical framework, we were never really going to get at some of the root influencers of racial inequity in maternal outcome, of community deprivation and how it has led to poor health before, during, and after pregnancies. And that we collectively as a system, and myself as an individual actor within that system, really needed to change how we were approaching this problem. You can go to the next slide, Michelle. So Cityblock Health has been providing advanced primary care services, as I said, currently in 4 different states in partnership with Medicaid payers for the last couple of years. And the way in which we approach this is value-based risk contracts with public payer entities, mostly managed care organizations, but in some cases a state entity. And we offer, through personalized care teams, neighborhood hubs, and purpose-built technology, which is our care management platform and digital app, wraparound service that is designed to provide 24/7 support to our members who are predominantly Black and Brown folks insured through Medicaid or Medicare, living in historically structurally marginalized communities where access may be severely limited. And many of our payer partners will stratify the population that gets attributed to us based on medical complexity, social need, or behavioral health needs. Go to the next slide. So in order to take care of this population, we have to build trust quickly. We work with primary care providers who may be assigned to folks in our network. And in other cases, we are the primary care provider for our population. And in order to build trust and maintain trust with folks, our model really centers around a community health partner who is a community health worker recruited and trained from the community where we're serving on a particular contract. The community health partner works in close partnership with a clinical care team, and we'll take a closer look at how we adapt that care team to pregnancy specifically. But our primary care teams may consist of a nurse practitioner, a physician, an RN care manager, and a behavioral health specialist. And our aim is to provide flexible care. And certainly in 2020, just to keep it real for a second and acknowledge where we all are, whether you're a payer or a provider or a consumer or user of healthcare services or all of the above, we know that care has had to get super flexible in this last year, and certainly the services we provide are no exception. So moving from providing mostly home visiting services, which is what we were doing at the end of 2019, or clinical visits in neighborhood hubs, to providing what we think of as virtual integrated care, where we're able to provide a telehealth visit or platform, but people can still access team-based care, to virtual care provided through digital application, or even being able to pair our telehealth services with a community paramedicine team that can show up in the home for someone who seems like they're having concerning symptoms, but who may not need to go to an emergency room or urgent care. That person, particularly in the time of COVID, may need something like an IV or oxygen or just a human to show up at their door and make sure that everything is okay. And we aim to provide that service while keeping acute utilization down, because we know that sometimes acute utilization does not meet complex member needs. So how do we think about applying this type of framework? You can move on to the next slide, to maternity care. During COVID, we realized in our population in Brooklyn, New York, that we have people in our primary care population who are becoming pregnant. And because of who we serve, these disproportionately were birthing people with medical complexity or social needs that were unmet, or an additional behavioral health diagnosis. And as folks' needs were being met less and less well by the traditional inpatient healthcare system, we found our members calling us for everything from, I don't know how to get in touch with my OB provider, to my OB provider hasn't called me for 3 months, or my visit just got canceled, or I was told I couldn't go to the emergency room, but I'm scared and I don't know what to do next. So we started designing what we think of as a primary maternity care solution. So taking our expertise and capability as an advanced primary care provider and applying it to the needs of someone who has all of the same needs that they had before they became pregnant, but is bringing those same needs into a new moment in their lives. So we think about this as being oriented around a couple of key pivot points. One, identifying folks who may want to get pregnant, be able to get pregnant, but not want to be pregnant, or be pregnant early in their course so that we can provide that wraparound support really early. And in some cases, we'll identify the member through our collaborations with payer partners. In others, we identify pregnancy because the member is telling us themselves, or on basic outreach, we ask every single person who comes into our program, is there any chance that you could be pregnant? And what does the idea of becoming pregnant seem like to you? How does that make you feel? We immediately connect anyone who becomes pregnant in our system with a trained perinatal community health partner who has community-based doula training. And one of the reasons that we're able to do this, we'll get more into this in a moment in our discussion, is our value-based payment contracts. And I think we'll talk a little bit about how value-based payment is critical to changing the paradigm on maternity care and primary care, because so much of an effective model needs to orient around meeting folks in the community with role types and training that is not what is traditionally received, and I say this with all humility, by an OBGYN or even a physician primary care provider or RN case manager. We extend our model by thinking about our prenatal providers as primary care providers during pregnancy, wrapping around the obstetrician, wrapping around that inpatient episode childbirth, and then focusing a lot of our team-based approach on the postpartum period. You can move on to the next slide. And we enable our kind of digital and telehealth service with a tech platform that is designed for folks with social needs. So this is just an example of what a care team in our maternity setting may look like in terms of a midwife or nurse practitioner leading the care, working with the inpatient delivery provider, if it happens to be an OB, focusing on RN care management, behavioral health specialists, and that community health partner. And our vision is really that we draw birth centers and other high quality birth facilities into a value-based payment network in partnership with payers. And so as we advance this vision, taking what we've learned in our current markets, we can move on to the next slide. We've really been out on the road talking to Medicaid payers around what their needs are, what are the pain points that they're seeing, as we think about integrating primary maternity care into what we do as a primary care organization, and thinking together about how we pay for this episode differently, in addition to focusing on birthing people after the pregnancy has ended, however a pregnancy may end, whether that's an abortion, a miscarriage, a birth, whatever the case may be. And what we're learning from our prospective payer partners is that payers are concerned about their ability to meet the needs of really complex situations like substance use, severe mental illness, and pregnancy. Payers recognize that a digital application by itself is not primary maternity care, and that inpatient hospital utilization is also not primary maternity care. And that we're going to have to really come together as a group of stakeholders across the spectrum to understand how we maintain that kind of community-based wrap and support with trust and buy-in from the people who are most impacted by these issues, with attention to some of the racial equity issues that are in play and the community neighborhood factors that are in play, to meet people's needs. And there's some quotes here just both from payers who recognize, this quote at the bottom, you don't let go of someone else in our population after they have a heart attack, but the system is kind of driving us to let go of people right after they give birth, and it doesn't really make sense. To our members' recognition that the way that the traditional system has been set up is just fundamentally not working. After I had my baby, I needed someone to help me deal with my depression, but I needed someone to see me right then and there. And the RN case manager that called this member on the phone was sort of mailing a pamphlet that reached the home 2 weeks later, and that just wasn't what that person needed right at that moment. And I do just want to acknowledge as my last point that value-based payment offers a lot of hope, but we do need to really think creatively around how to define these episodes so that they extend for a decent amount of time after the end of a pregnancy and encompass that neonatal care so that we can provide lactation services, home visiting, support with developmental screening, and recognize that the people that we are serving are aware of the ways in which the system is failing them, both in terms of the ways in which these impacts disproportionately affect Black folks and Indigenous folks, that there are a lot of reasons that people may not trust the hospitals and emergency rooms that they've been told to turn to, and that we need to pay for solutions differently on the community side and reorganize our systems of care, and that primary care providers may be uniquely suited to fill what today is a real missing piece in the puzzle. So again, we have to get to questions, so I'll stop there and look forward to hearing some discussion.
Thank you very much. So I want to remind folks to chat in your questions, and thank you very much to Amy and Pooja for sharing your experience and your expertise in this space. I'm going to pause for a minute and see if we have any questions coming in. And I think I'll go ahead and ask a question. So I know we've heard now some examples about what primary care could look like as an integrated health model compared to a separate primary care, maternity care entity. I want to ask Amy and Pooja, if you have, if you had a magic wand and you could ask for something to reinvent these systems, because we know that both care redesign and the payment reform to allow that care redesign is quite challenging. What are some of the levers that you would pull on quickly? We mentioned a lot of different tools here, but what would be the first place you would start?
Pooja, do you have any big ideas?
What you can go first. I'm like formulating my response to that.
Yeah, I think, when I'm thinking who's on this call as far as payers and health systems, I do think there's a real opportunity around expanding the use of midwives and midwifery-led models. And there are some pretty fundamental things that make it hard to do that. In the state that I live in, which is Connecticut, the Medicaid program doesn't pay midwives. They pay midwives 85% of what physicians get paid. And they're trying to figure out how to solve the kinds of problems that midwives can help solve. And it's been interesting to me. I'm a huge fan of doulas and think there's a major opportunity there. But I think functionally, it's very difficult to figure out how to incorporate doulas, which is a whole new profession, and we have to create a bunch of infrastructure to figure out how to get them paid or part of the bundle when midwives are already can accept payment for services. So I think there's some relatively basic structural things that we can do to help just at least remove some of the barriers to expansion of midwifery, particularly in areas that don't have services at all or that are underserved or are deserts. I think simplifying a lot of the regulations around birth centers as well, and there's going to be some model regulations for states to consider adopting to either modernize or bring in facility regs early next year. So those are my two magic wands.
I think just some things to add to that. Definitely one of our focuses has been what are the tools that Medicaid payers or any kind of payer already have today that can be better deployed around this issue. So thinking about that early identification of who has reproductive capacity in a population and what do they need, just regardless of whether they are pregnant, how do we use the data that we have to identify who is becoming pregnant, what complexities they're facing during pregnancy. I certainly, as I mentioned, see value-based payment as a critical link in this, not by itself, but in tied to real quality improvement efforts and community-based capacity building. I think we have behavioral health and primary care resources in our community. They are just not traditionally made accessible to people with reproductive capacity before the pregnancy. And certainly as an obstetrician, even during a pregnancy, OBGYN practices are remarkably isolated from behavioral health resources in many places, and the large big hospital systems and academic centers are some of the only exceptions to that rule, but everyone can't go to a large academic center or a large hospital system for their care. So how do we think about integration within our existing systems? And then the last thing that we haven't mentioned so far today is just this issue of churn and coverage, which we, as all different actors in the system, tend to just capitulate to being like, okay, well, we're going to lose this person a couple of months after they give birth. And for many payers and employers, that may not actually be the case. And so how are we thinking about supporting the parent and the neonatal dyad while we are working on this policy issue of stabilizing coverage, at least for a year, but ongoing postpartum? And thinking about delegated primary care providers who do have community health workers working in their systems and care coordination resources who are just profoundly uncomfortable with managing issues as they come up around maternity. And so that episode kind of just gets sort of carved out from the way we think about our interventions.
Thank you both very much. And I think on that last point was one of the questions we got in our registration, which was how do we manage resistance and fear around the definition of primary maternity care? Any other thoughts to share on that issue, particularly on how to build capacity in communities? And I know we only have about a minute left, and then we'll close everybody out.
I was distracted by reading the other question that's in the in the comment field about midwifery. It should be stated that midwives have just had a big win in California to be able to practice independently and expand. So that's a real opportunity to expand midwifery in the state. So do you mind if I answer this question briefly? And then
Please go ahead. Thank you.
So the question from Kathleen Belzer is, there's only so much CNMs can do here, but moving to more birth centers and community-based care seems so possible, but so overwhelming. Often these startups land on CNMs who rarely ever have the funding to do so. Do you have any suggestions for how to make this a reality? I do think there's a lot of interest in kind of tools and support for early birth center startup. I think there's a lot of philanthropic interest as well as private funder interest in these models. So I do feel like midwives who could partner with a business partner would actually be able to get something off the ground, and it's a good landscape for that currently. And I think, it's one of my goals and mission of primary maternity care is to be able to support those as well, and to be able to bring some sort of tools and help with navigating regulatory landscape and just kind of startup. So I'd be happy to talk to anybody about that.
Thank you very much, Amy. And I know we're a minute over, so I want to close us out, but I want to just extend a huge thank you, Amy and Pooja, for sharing your wisdom and expertise. And please reach out to us at PBGH and CQC if you'd like to learn more about some of the programs that we're designing for 2021 and beyond. We are very excited about this idea of the intersection of primary care and maternity care. I think there's a lot to consider and a lot of care redesign and payment reform opportunities in this space. So I want to thank you everybody for joining. And with that, I'll turn back over Michelle and Krishna. Let me know if there's any other wrap up to do. If not, we'll close this out. Okay, I think that's it. Thank you very much, everybody.
Thanks, everyone.
Thank you, everybody. Thanks for joining.
Thank you. Take care.
We will
everyone.
be sending out resources